as we can. Once the disease is under control, then do something to kind of maintain the remission. The second thing, that we're constantly dealing with is the side effects, and as I said, those tend to get better. And then the third thing is, unfortunately, all of you've had to go through myeloma in the middle of a pandemic. And unfortunately, that for myeloma patients has really been a devastating problem, because people with myeloma don't have good immune responses to things. And vaccines haven't been that great for patients with myeloma. They help, but they haven't been perfect and protective. So people, especially early on in the pandemic, had a real problem with COVID. Fortunately, now that we've got a lot of good therapeutics, we're not seeing the same kind of devastation from COVID as we did before. So now we let people get back to their life. To sit next to me, we're both not wearing a mask and we're getting out and about. But he knows that if he were to get COVID, his first phone call is to me and say, hey, I've got COVID. And then we've got the pharmacist on speed dial to give him some Paxlovid to get him a treatment. With that approach, we've done really, really, really well. So I don't know if everyone else wants to talk a little bit about their experience with myeloma, questions about drugs, treatment, side effects, how they've been dealing with the pandemic, but I'm open to just about any question.
So how about that? Does anyone on the Zoom want to chime in and talk about their experiences with myeloma, and we can kind of take it from there. It's always really interesting. Joanne, do you want to?
Yes. Good morning.
Morning.
So clearly I'm still in the early phases of my treatment. I had a stem cell transplant in February, and I just passed my 100 days. So you can see I'm just starting to grow my hair back. So the question that I have that I actually posed to my support group last night, and I'm really struggling with, is what is it safe for me to do at this point? Because, I've been released, okay, your 100 days, all your restrictions with the BMT team, they're like, we're done with you. And I don't really know at this point what it's safe for me to do. I mean, I realize I'm still immunocompromised. I realize I still have, myeloma, and I have to be careful, but I don't really know what I can do. And, yeah, so I'm struggling with that.
So I'll give you my perspective, but the truth is you've got better experts in the room on this subject than I am, and I'll ask some of those people. After the transplant, after you hit 100 days, that's a big milestone. Your body's kind of started to recover. You're hopefully starting to feel better from the transplant. Your immune system from the transplant is still like a young toddler. And that's why you're going to start to get your vaccinations and be revaccinated, because your immune system basically kind of got erased and it's got to restart. So you're going to be a little bit more susceptible to getting small viruses, little infections. But again, this is the start of that maintenance that I talked about at the beginning. We want you to go out and live. So you should be doing the things that you normally do. Try to get your life, back together. And then you just need to be careful. If you start to get sick, that's when you communicate back with your oncologist, with your transplant team. And it may be, if you get the flu, that you're going to need to get, Tamiflu. If you get an infection or something that's going on, it's not, oh, well, I'll take some Tylenol. Maybe I'll call the doctor in a week. You call the doctor, let them know something is going on. But really, at this point, I'd like to see you out and about doing things and kind of returning, to your life. You're going to be starting your maintenance treatment. And maintenance treatment isn't, to continue to keep your life on hold. This is when you start living again. And the best advice I give patients is, don't be a patient, start living. And the whole purpose of everything that you've done this far is so you can continue to live. Sid, if you want to talk about how you reintegrated after a transplant, or
right. I think you're very tired for a while, and it takes a while to get readjusted.
I actually sailed through. I mean, they told me, my BMT team told me I'm like 1% of all patients. Like I had, like the transplant was, I hate to say it, no big deal. I mean, I didn't feel sick at all. I've been fine. So I've been very, very, very fortunate. I mean, I'm not tired. I've started my maintenance therapy, and so I'm ready to go.
Now you heard the best advice. Go.
Yeah, you're returning to your normal life as best you can. If you get tired, you'll take it easy a little bit, but there's no reason why you can't live your life now. We go forward.
So I should still be masking up though when I'm with groups of people and things, just to be on the safe side, right? I mean, that's what I'm.
You know, if your goal is to never get another infection, you know, again, then I think you can mask up and you can live in a bubble. There's a point that you're going to have to kind of start to go on with your life and drop, you know, the masks and do things and kind of live and take some chances. You know, if you want to live a completely safe life, then I tell you, don't leave the house and don't go in the car, because if you go in the car, bad things can happen to you. But what you do is you go in the car, you know, you put a seatbelt on and you go where you need to go. So if you were going to, you know, a rock concert and there's tens of thousands of people sitting in the middle and you wanted to go now, maybe wear a mask, for that. But if you wanted to go out and have dinner with your friends at a restaurant, I'd go. I'd try to enjoy life and know that if you get some kind of infection, now there's some treatments for it. The big difference before is that it was a novel virus. We didn't know how to take care of it, and there were no treatments. And so when people got sick, there was nothing we can do. So we masked up, we kept away until, you know, science kind of caught up with things. And now if people get sick, we can at least treat it. You could have made the same argument 4 years ago after a transplant that you just mask up because you were afraid of flu or RSV or some of the other things that are, you know, out there. Viruses and infections aren't going to go away. You can't continue to put your life on hold. Go ahead and live. That's why you went through all this.
Thank you. That makes me feel so much better, because I feel like, what's the point of all of this if I can't like live my life, right? Thank you.
Point of this maintenance treat, this is put the treatments behind, you're kind of doing something, but go ahead and live.
Thank you.
Welcome.
Does anyone else want to discuss their their specific circumstance and ask questions about, you know, what you're doing? It's kind of nice when we all talk together about you know, what you're going through, because I'm sure as you know, as you're going through it, so are the rest of you, or you have gone through some of this. So speak up, please. Jerry, you want to say anything?
I might mention that I had my second MRD test a month ago. The first one was about 18 months ago, and they sent the blood sample out to the lab out west that does the clono SEQ test, where they look at 1 million cells. And 18 months ago, they found 18 cells out of 1 million. So that made me MRD positive. The last test they ran a couple weeks ago was 3 cells out of 1 million. So I'm still MRD positive, but the numbers are going down.
That's really good.
That's fantastic. And that's why I probably wouldn't get up on this MRD. Look at you, you're doing good, you're living, you're getting better. And people say your MRD is positive. They say, so what? Keep living, don't focus on that number, and know that especially during these maintenance phases, a lot of times it's not just keeping the status quo, but slowly people continue to get better and better and better. Even when people don't get MRD, people do amazing. And so, you know, MRD is a great research tool for us to try to look at what drugs might be good drugs going in the future, and the deeper the responses might mean before we can get initial survival data, it's there. But I really don't get hung up on MRD, or, you know, if you still have protein that's showing in your blood, because people can do great for years and years and years with these things.
How often are you checking it?
I don't check MRD. MRD it doesn't have at this point meaning. So if you're MRD positive, I don't change your treatment trying to get you to MRD. It really is a research tool right now. So if I'm trying to come up with treatments for myeloma. I'm not a research person, and I'm trying to pick a drug. I've got to run a race. I give treatments to group A and group B. Well, in order to find out which of those groups do better, I got to wait years to see if one group's doing better than another. Well, that means it takes a lot longer to get drugs to market. So if I can use a surrogate to say, okay, drug A got more people into MRD, which would be a surrogate for doing well or surrogate for response, then that drug may have a lot more promise than drug, B. So from a research perspective, it's great. And that's why almost every research trial that we do now has MRD as a marker. But as a treatment goal right now, really hasn't changed what we do, which is why we routinely, don't do it.
I might add to that, Doctor, that relative to getting back to normal, about 2 weeks ago, I jumped out of an airplane at 10,000 feet. And I turned it into a fundraiser for IMF, and I'm up to $5,700.
Good.
Well,
Maybe at
that's,
the next-
that's living.
I think at the next wine and dine, we'll have a contest to see how many myeloma patients can jump out of the plane. Amazing, really amazing. Sid,
Thank you.
I think Sharon would have something to say about it.
Thoughts? Anybody else want to comment about what they're doing right now and what's going on? So please do. Yes, Nancy, go ahead. Unmute.
Hi, I'm actually calling in from Chicago, Illinois. My understanding is there's no support group here, believe it or not, at Northwestern University Hospital, Northwestern Memorial Hospital or Gilda's Club. And if anybody knows of anything, I'd be happy to hear about it. I heard about this. My cousin sent me an article from the Detroit Jewish News about Sid Moss. So thank you, Mr. Moss. And so I did my Google searches and I found Michelle. I am going through treatment like the second phase. It was the first 9 weeks every week and a second 9 weeks every other week. I'm towards the end of it. We're hopefully going to harvest my stem cells in July, the third week of July, but my cardiologist is not signing off on it yet. So that's put a little glitch into things. I go for a stress test tomorrow, which hopefully will be good since I just had chemo infusion yesterday. So who knows how I'll feel. But I just wanted to say thank you for letting me join this by Zoom. I'm taking notes. I'm sure I will have questions. Assuming we harvest in July, we may not do the stem cell replacement until January because as Joanne said, you get very tired. I was in the process of thinking of closing down my business at the end of the year. So my doctor, who's Jayesh Mehta at Northwestern, suggested just close your business. Don't be stressed out. If there's a reason we need to do it before January, we will. But otherwise, close your business and then do that. I've been very fortunate. I've had an office in my home since 2000. So COVID didn't affect me in terms of work. And believe it or not, a lot of people still mask here in the Chicago area. So we never stopped taking off the mask, even though I was vaccinated, not the recent one in April, but been vaccinated. And I was diagnosed in December. So some of these acronyms are new to me, so I'm just writing them down. But I just wanted to say thank you, and I'm sure that I'll have questions in the future. And depending on how I feel in September, maybe I'll join you guys since, which I may not have said, I am a Detroit girl, still a Tigers fan after leaving there many years ago. But I just wanted to say thank you. And if anybody knows of anything in Chicago, let me know.
Nancy, sorry, Dr. Denner, go ahead, Doctor.
I'm gonna say good luck on your journey, and maybe Michelle can get you some of the numbers of the support groups here in Detroit. Allow people from Chicago to be part of them, and you potentially can, zoom in. As you make decisions about your business, if closing your business is the right thing for you because it's that time, then I think you can close your business. But Sid's been doing this for 13 years. I wouldn't say that,
50.
huh? For my, but I didn't say close your business, stop living, because eventually you're gonna be left with, you're done with the treatment, you're done with the transplant, you're on maintenance. And if you wanted to continue to run your business, you probably could. You may need to take a pause for your business during the transplant when you're tired of doing things, but sometimes, you know, totally upending your life because you've got this disease, you may have buyer's remorse in the end and say, I'm sorry, you know, that I did this, because the idea is for you to live, you know, a long, long time, and you want to live with this disease and not let this disease change who you are.
My goal was actually to always close down the business at the end of this year before this even started. And my main staff person is retiring at the end of the year. My husband is older than I am. I get Social Security at the end of the year, yay. And so it was a plan. So, and to close down my business, it's still going to take me 6 months or a year to actually literally close it down because of invoicing and stuff like that. So I will work a little bit. So, but yeah, this was always the plan. And that's why I think Dr. Maida said, this was your plan, go with your plan.
I agree with that. So we're going to wish you a long and healthy retirement after all this.
Yes, I have, long story short, I have, my second goal is to sell a lot of antiques that my parents collected when they had an antique shop on Hamilton and 6 Mile in the 60s, early 70s, and I still have a lot of that stuff. So that is my second career.
Nancy, last night in our support group meeting, we had a speaker from the LLS, and she gave us the contact information for the Michigan and Indiana outreach coordinator for the LLS. And by contacting her, she can maybe direct you to a support group in that area. And I will put that information in the chat.
Thank you. Appreciate it.
Okay, anyone else have a terrible secondary feedback? Oh, in the, can you all hear us okay? You can, because I got in the chat, Teresa, you said that you have secondary feedback?
Yeah, but later on in the chat, you'll see that I said the feedback has resolved.
Oh, okay. Oh, I see. Okay. Okay, great. Do you want to mention anything about you and what's going on with you?
Hi, hello to fellow Burke, Terry Burke, I see down there. And then I'm a little longer into my course of therapy. I'm actually just May 18th, went to Henry Ford Hospital, Maine, and joined the Magnetism 9 clinical trial study for elrantamab bispecific antibody. And so I'm a lot further than Joanne, and I know Joanne and Jerry from the Ann Arbor multiple myeloma support group. And it's kicking my butt. It's a really, the fatigue is phenomenal. Thank God I get to go off the steroids and the Decadron and the Benadryl prior to each dose. And I'm still on the step up where I'm only at 76 milligrams. I think if I've read the protocol correctly, I go up to 112 milligrams in a couple of weeks. But what I'm most looking forward to is going to the every 2 week and then the every month as quickly as possible. So I'll keep you updated on how things are going. No real major adverse effects other than the fatigue, rash, that kind of a thing. I saw Nancy had her hand up.
Oh.
It's quite an adventure. 103 temp was something I hadn't experienced since I was a kid, maybe. The Decadron prior to each dose, the first 3 doses was 20 milligrams, and it set off a round of irritated GERD that shot up this cough, and I just can't seem to get rid of it. I went to work yesterday. I have to work Monday, Tuesday, Wednesdays. I'm a pharmacist for Henry Ford Health System. And for the first time since I was in my 20s and hungover, I put my head on the desk at work and rested. That's how tired I was.
That's a pretty amazing story that you're going through all this, participating on a clinical trial. and still working a full job. So I take my hats off to you. That's truly living.
Well, fortunately, the job is part-time, Monday, Tuesday, Wednesdays, because that allows me Thursdays for my chemos or whatever I'm, or whatever injection, or prior to that, it was Darzalex, and trying to get the numbers down. But that gives me Friday, Saturday, and Sunday to recover. But I feel like I'm spending 4 or 5 days recovering, 3 days working out of a 7-day week. I'm really hoping to get over some of this and get to a point where I'm tolerating it better so I can get back to a life this summer.
We wish you absolute, best luck. Take care of
Thank
yourself.
you. I will. I'll keep everybody informed. I haven't had any of them. No ICANS, no CRS. I wrote the ball is red every 2 hours, every 4 hours for way too many off for the first 2 doses. That was interesting. They kept asking me who was president, and I wouldn't give them. I told them, I says, I can't give them my political affiliation. So as long as I answered with the same response each time, they were cool. I just made everybody laugh. That's my story.
That's a good one.
Thank you, doctor.
You're welcome.
Anyone else want to chime in right now?
People have questions about therapy, things they've read, advances.
Right. Can you tell us about, let's see, Joanne, are you raising your hand?
Well, I don't want to, because I want to give a chance for everybody to speak, but if nobody has anything, I do have a question. So I want to know, so how, so the venetoclax I know works when you have the 11-14 translocation. And what I'm wondering is, are they working on any therapies that address the +1Q? Because in the research that I've done, it seems that anywhere between 20 and 50% of patients have that cytogenetic abnormality. And because that abnormality can cause, worse PFS and OS, I was wondering if there's any, therapies that they're looking at to address that specific abnormality.
Sure. So when any people who have myeloma are diagnosed, one of the things that you've all gone through is a bone marrow biopsy. And during that bone marrow biopsy, you look under the microscope and you see how many plasma cells that are in the marrow. That's the myeloma. And then one of the things that we do, and we've been doing this for 50 or 60 years, is we grow the cells and we look at what kind of cytogenetic abnormalities that are there. And that's looking at the chromosomes and the genes for the myeloma. No different than when people do an amniocentesis. When people are pregnant, they look at the chromosomes that are there for the fetus and the baby to see if they've got all the right chromosomes. And in myeloma, there are multiple chromosome abnormalities. But that's a very, very gross look at what's going on. And some of those chromosome abnormalities are associated with changes in how the cell divides and what it does. And people who are in venetoclax, that chromosome abnormality is associated with a BCL2 abnormality, and that drug targets BCL2. Fortunately, we've progressed way beyond now cytogenetics, and cytogenetics is kind of this big picture look and says that there's something there. What we're now doing is next generation sequencing, where instead of looking at what the translocation is, which you could have a translocation and that could be associated with multiple different kinds of mutations within the cell. We're now actually sequencing out the individual DNA mutations. And as we sequence out these individual DNA mutations, and many of you are participating on trials that we're doing that, those are the drugs that we're now trying to target to those individual mutations. Now, what we found over the years in oncology and cancer in general, as we find some of these mutations, we're able to derive drugs that target these mutations. So there's a very rare mutation called NTRK. It's present in about 1 or 2% of cancers. People targeted this, noticed it was there. People got a drug that targeted NTRK. And when they did that, all of a sudden with the pill, 80% of people with cancers that didn't respond to treatment went into remission like that. And they stay in remission for long periods of time. Probably 20 years ago, people had something in a disease called chronic myelogenous leukemia. And those people had cytogenetics that were abnormal. And that was called a Philadelphia chromosome. Well, that Philadelphia chromosome, when you look at it more on a molecular basis, it was a abnormality in the cell that caused something called BCR-ABL. It was an abnormal protein that the cell made. And so people said, oh, well, this Philadelphia chromosome targets BCR8, makes a new protein called BCR-ABL. Maybe we can come up with a drug that will target the BCR-ABL. And a drug called Gleevec came out. And all of a sudden, patients who had CML all went into remission and started to stay in remission. Well, when that happened, then people said, well, now we know what the target is. We can invent drugs that are potentially better than Gleevec. Well, we took a disease that was incurable when I started fellowship to a disease that's probably curable for a lot of people who go on treatment for 3 years. And a lot of those patients can stop treatment and the disease never comes back. So kind of targeting things and looking for what we call targeted therapy is probably the most active phase in myeloma and in cancer research. And that's why we're doing the cloud trial. We're doing this next generation sequencing and then coming up with drugs that target individual mutations. So eventually, instead of saying I have myeloma or I've got myeloma with the chromosome abnormality, you'll say I've got myeloma with such and such protein abnormality, and then we can start to target it. I hope that helps.
It's over my head, but
If it's not clear, ask, I'll try to clarify it.
I don't know. It's, I mean.
I have a
Maybe
question.
should ask them again.
So my neighbor is 48 and her daughter is graduating high school this year. And so she's in the midst of like, you know, this is her only child graduating high school, planning her open house, and she was diagnosed. So, I am in industry, but I'm not in the myeloma space. So I'm just curious about, the best things that I can do, and this is really for the group and for you, Dr. Margolis, just to support her. I mean, this is a brand new diet. It's just, I feel like it's so disrupted her life, even though things have changed in this space, just the best way that you've been supported or that I could support her. Any resources or places that I can direct her to. I actually should have invited her to this call, so that's on me, but that's what I'm looking for, is just ways that I can support her through this process.
So I think the first and most important thing is that you need to let people know there's hope.
Yeah.
And the reason for having these calls, the reason for having the wine and dine, having these things is that people need to know their life's not over. And it wasn't long ago when people got this diagnosis, they basically were told, get your affairs together. You're not going to be around. You're not going to see your kids graduate from college. That's part of why the Myeloma Foundation actually got started, because that's what the founder was actually told. And that's just not true now. So there's hope. What I usually do when people are invited, I tell them the story and I let them know that they will actually be invited to the wine and dine as a guest. And then one of the things that we usually do at the wine and dine as a guest is I ask people to turn around and look around and try to figure out who's a patient and who's just a guest. And for the most part, you can't. The second part is that she's going to need some treatment for this. And this first part of the treatment is going to be hard. And she's going to have some things that are going to change her life during, you know, this induction phase. And being a young woman, she is going to end up with a stem cell transplant. So this is going to be a journey. But this journey is for, you know, a hard part at the beginning. She's going to get through the transplant, and then there's kind of a light at the end of the tunnel. And I think as she goes through this, she's going to have to understand that there's hope here. She's going to get through this, and that she's going to need some support with people like this who are on these phone calls, the support groups to get through all this, but things are going to be okay. I think that what sometimes people start to do with this is they also start to overanalyze this. And so you get on the internet looking for, you know, a million places do I all have to go? Well, the good news is this isn't a rare disease anymore. Most doctors and most oncologists know how to treat myeloma. In this situation, she's either going to get 3 drugs or 4 drugs. Everybody knows what the 3 and 4 drugs are going to be that you're going to get for this. Someone who's young like this is going to move on to get a stem cell transplant, and she's going to go on to get maintenance. And she can go to any of the big centers here in the state of Michigan. She can fly to MD Anderson. She can fly. It's all going to be the same, because this is all kind of worked itself out now. And so she can rest assured that it's not going to be on her to solve her problem. In the old days of myeloma, that wasn't true. And people didn't have uniform treatments. They didn't have access to all the good drugs, and the communication lines for everything were not all put together. Part of the Multiple Myeloma Foundation was to put all those things together. And when the foundation was put together, one of the problems was that things were really disjointed. And the founder for this went to Harvard and got her opinion. And then she said, well, if I went to Johns Hopkins, what were they going to say? And they said, I don't know, go there and they'll give you your opinion. And then she called another place and said, well, were they? We don't know. But she couldn't believe that everyone wasn't communicating. We used to go to the ASCO and ASH meetings for myeloma, and no one was in the audience. None of the doctors, came. It was an orphan disease that, people have been treating the same for, 30 years. That's absolutely changed. And she needs to know that, fortunately, there's been tremendous progress in this. You're welcome.
Can I just add one thing for your neighbor? If she wants to, look some things up and try to educate herself, which I would recommend, because the more you know about your disease, the better, educated you are, the better you are at making decisions. But the best place is the IMF, the International Myeloma Foundation. If she looks that up online, they have the best information for her. It's very reliable. It's a really good resource. The IMF, International Myeloma Foundation.
Thank you, Joanne.
Yeah.
I think that's part of the other key is if you're gonna do things and look things up, stick with those things. The worst doctor to see is Dr. Google. And part of the problem is that people start Googling things, you find out things that really don't apply to you. You don't know in the context where these things kind of are. And so really it's getting information that's at least collated and put together in an understandable way, that been screened, through things and been vetted by, multiple authorities and doctors.
And invite her to come to our next.
I will. She's actually in Grand Rapids, but so she might be on there, but I'll make sure. That's why I asked.
She can still come to the wine and dine.
That's, yeah, there you go.
I was gonna say, Courtney.
Yeah.
My best friend's father,
Uh-huh.
I invited him, she and him to the wine and dine
Oh,
last year. And he totally enjoyed it. He still talked about that. That was the highlight of his year. He was the one who went to drinking Coca-Cola.
I wonder.
Remember that?
I'm like, it was a gem. What a.
Yes, and so
Oh.
it's made his life.
It's an important thing, especially when you're diagnosed, because you know you have something to look forward to. You're gonna be there. And every year people go there. It's another milestone that people hit.
Yeah.
Yep. Yeah, and she can come from Grand Rapids. It's not that, and spend the night at the Westin.
Yeah,
It's
I do
a-
like.
Your favorite place.
Yeah, it's better than Leslie.
And Nancy, you can come too. From Chicago, spend the night at the Westin and have a good time at Wine and Dine the Deep. You should come. It's quite a night.
I may, because I have things I have to do in the Detroit area, so you never know.
Great. So, anybody else want to speak up and talk about everything that they know?
I've got another question, Doctor. I've been on Darzalex maintenance for 2.5 years. But after 2 years, when it came time to get my MMR vaccine, they said I couldn't get it. And they said it was because I was on Darzalex. So my conclusion is that you're weighing the risk of getting MMR versus the risk of stopping Darzalex for a while you get your vaccination. What's your take on that?
I think you said it exactly, right. Part of the problem is that some vaccines have live attenuated virus, and the measles part of that vaccine has live attenuated virus. And when your immune system doesn't work, theoretically you can get, measles. There are some vaccines and things that you're doing to continue the herd immunity that the rest of the group and the population enjoys. So the truth is, measles and mumps and rubella are extraordinarily rare diseases in the community. And by keeping everyone vaccinated, it keeps the whole community safe. But for every, a single individual to get it, you're probably safe because everyone else got their vaccine. Part of vaccine therapy is you're taking vaccines not just for you, you're taking it for everybody else. So if everyone else continues to get vaccinated, they're protecting people like yourself that can't get vaccinated. And if you look at most of the outbreaks that you see of measles, they're usually in communities where the community has kind of shunned the vaccine, and now there's no herd community, and that kind of runs rapid through that community. So for you, I think you're making the right choice. It's much more important that you stay on DARS and then rely on all the rest of us to continue to get vaccinated.
Well, but one of the things I've noticed is there hasn't been a lot of information for patients on Darzalex that they cannot get that vaccine. It's kind of like until you ask your doctor, you don't know. There doesn't seem to be any public broadcasting of that issue.
It's because most adults don't need to get an MMR vaccine. They've already been vaccinated, and most people think that vaccine lasts for most of the lifetime. Where it becomes an issue is that after you've had a stem cell transplant, you basically booted away your immunity, and that's why we revaccinate people after their stem cell transplant. And that's when the MMR becomes a much bigger issue. And so it's for a small subset of the adult population that needs to be revaccinated. And that's why really the best source of that information is usually from the stem cell doc. It usually doesn't come up in the rest of the medical community. And that's why a lot of the adult docs, we don't even keep MMR in our office because it's something that we don't have to vaccinate people with.
You're going back and revaccinating just like your child.
Same childhood stuff, so you have to revaccinate for tetanus, revaccinate for hepatitis. We revaccinate now since we can do it as kids for chickenpox. Yeah, the whole thing.
Jerry, my vaccination schedule that I just got from Adrian when I had my 100-day appointment. So the MMR is at 24 months, and it says not if I'm on my maintenance therapy. So I'm going to be skipping that MMR as well. So, and I'm on Revlimid and Cripolis.
Well, then they've changed that piece of paper, because when I got that paper 3 years ago, that qualification was not listed.
So they added that, yeah. So it says not while on current maintenance regimen for the MMR.
Right. But just to throw a wrench into that whole issue, doctor, what if you're planning to go to Egypt in November?
So, the problem is the farther you go out of the country, you lie on kind of the herd immunity that's, that's in that country. And as you start to go into places that are less vaccinated, then there's more disease that's going there. But even in those communities, there's still not lots and lots of measles that are going on. And so you don't have to worry too much. The real problem with measles is that it's very, very contagious. And measles is a true airborne, disease. And people, when there's measles going around, someone who was in a waiting room that got measles, coughed in the waiting room, left the waiting room, someone that came in after, you can kind of spread it. And that's why we're so aggressive about vaccinating the community. But if you remember here, when someone gets measles, none of us have seen measles. They had we had a case of measles at Beaumont. They had to pull out a doctor who was like 80 years old, who was in retirement, and said, hey, what is this? What do we do? Because, all of us have just read about it in a book. We just don't see it. So for the most part, you're safe because the herd immunity works.
Yeah.
So Mary, you had a question before about heredity. Do you want to ask that question here?
Yeah, I can ask it. Wasn't it last time, right? I asked about my nephew. Yeah.
Mhm.
Well, my brother died from non-Hodgkin's lymphoma. And then my other brother died from multiple myeloma. And then my nephew has it now. And but he's all done with treatments and everything, and he's in really a good place. Even after his treatment, he had hip surgery. He had another surgery, I can't remember this, but then he went on a cruise. So he's living his life. He's doing really good. He's doing really good. But when we were the time we were at Sheila, there was a researcher from, I believe, New York, who keeps in contact with my nephew, because my nephew wanted to know if that was a hereditary thing, in the line of lymphoma.
So for myeloma, we're still trying to figure out what the causes is of myeloma. There is certainly clustering of myelomas, where if you kind of look on the map, there's certain areas that appear to have higher associations with myeloma. There are families that have myeloma clustered in their family, as well as other hematologic malignancies, which raises two possibilities. One, it could be some kind of genetic factor that's passed on that we haven't figured out. So we're looking at, now thousands and thousands and thousands of genes, trying to figure out if there's one that's clustering. And the reason that people have such an interest, if you find a family that's like this, what you want to do is sequence their genes and see if they all share kind of a common abnormal gene that might be passed along. That takes a lot of time. And for things that are still relatively rare diseases, it takes a lot of work. The second thing is that there's probably environmental factors. So if all of a sudden you found out that everybody lived next to 3 Mile Island, I think the answer is probably not that's genetics. It was probably radiation exposure or something else that happened, in the environment. And usually when you have genetic factors, it's usually a combination of that genetic factor and then something in the environment that kind of triggers it and pushes things over. So it's an area of very, very active research. And part of the reason it's so important is that because sometimes if you can identify what that gene is that got myeloma in the first place, you may be able to target that gene as part of the treatment. And we've seen that happen in breast cancer. So there's a gene called BRCA. Well, that gene, when we figured that out, and it was a cause of breast cancer, we've got drugs now that can target that gene as part of the treatment. And then the second thing that you can do is if you can identify that gene and screen for it, then you can potentially warn people and say, okay, you've got this gene, you're more susceptible to myeloma. There may be other drugs or other things that you need to avoid so you don't get myeloma. So it's a very, very active area of research, and having someone like your brother participate in that research and kind of continuing to give us blood samples and stuff to sort this out is really, really helpful.
Yeah, well, we have a pretty big family, so out of 22 grandkids, there's only Stan, the one that has multiple, was the only one to carry the maiden name over, okay? So all the other are girls from the other side, but they're other families. So the 3 boys that were on this side are the 3 that had cancer. So it has, I assume it's genetic.
It certainly could be.
But none of the girls had it, so.
Well, multiple myeloma is also something that is, am I right about this? I mean, that it's male, that it's more prevalent in males than in females, and also in the Black population.
That's correct.
Is that right?
All right. Other questions?
Yeah. Does anyone else have questions? We do have to have a hard stop at 8 o'clock, and
Has there been any research of why it's more so in the Black population?
So it's that same issue, is it a genetic piece that we're missing and we haven't figured out that gene? Is it environmental about where that population is living, what the population is, exposed to, or some kind of combination? And so everyone's trying to sort these things together. And as you get these kind of clusters of things, you start to sort this out. And going back to the most famous, genetic gene is breast cancer or BRCA. People first started to notice that this was a gene in people who were Ashkenazi Jewish, all happened to have this this abnormality that they got early breast cancers. And they said, well, there's got to be something, related to this piece. And they also noticed that people got early pancreas cancers. Well, they found this gene that was associated in both families. So it's kind of noticing that there's something going on with one segment of the population and then trying to sort out where that abnormality is. But sometimes it's like looking for a needle in a haystack. You're looking at thousands and thousands of genes. You don't know which is the causative gene. And then you got to compare that affected gene to the rest of the population.
Not only that, it's almost a call to action
Yeah.
of in the Black population.
Exactly. I
And
know.
because I know it is getting the Black population to
Involved in
get
study.
to the doctor,
Yeah,
which is
One.
a huge issue. And
to involve in study.
involved in studies, and as opposed to the Ashkenazi Jews, it was like, get to the doctor, get in these studies, and so it's a double-edged sword of
Yeah,
trying to get into the study,
right, because of the ski year.
Yeah,
Situation.
I we saw that recently, I
Right.
get it.
So,
Yes, Teresa?
I try.
Hi, I heard a pretty good expression when my family was asking about, oh, shall we get tested? I said, well, I don't know that you necessarily get tested, but in this case, a lot of the doctors, when they hear hoofbeats, they're going to think horses, and perhaps they should think zebras. In the sense that if you're going to get sick, you need to mention that, I've got multiple myeloma, so that they can at least rule it out for whatever purpose. And it's kind of hard. A lot of doctors see anemia, they think lots of other things, or they see a bone fracture and trying to figure it out. So that's what I've been telling my kinfolk. I said, well, if you get sick or something goes wrong, be sure to mention it to the doctor so that he can rule it out, because again, he's going to see a set of symptoms and think hoofbeats and think horses, when in fact he should be thinking the odd man out of zebras. Just another way to express it. That's all I wanted to share.
That's interesting. That's a good way to share it. It's a good way to think about it. So anything else? Because we're going to wrap this up because Dr. has patients real. So we are going to actually probably close it down, and Sid has to leave real soon too. If there's any more, like one more question we can take, and then we're gonna have to hard stop it.
Probably sits looking for a plane to jump out of.
Think we pulled that out.
Go higher than 10,000.
I felt safer going down than I did going up because the plane was built almost when I was born.
Was that the first time you ever did it?
Yes, it was my first time. I loved it. I'd do it again in a minute.
God bless.
I don't know.
It's not
All right, well, Anthony, I'm closing this down now because people have to get out of here. So, so thank you all for joining us. Very interesting conversation. Thank you, Dr. Margolis.
You're
for
welcome.
taking the
Thank
time.
you.
Have
We
another-
really appreciate it. And keep in touch, check our website for and I'm gonna send out emails to everyone too about our next one coming up. So
June
21st.
And look forward to seeing everyone at the Wine and Dine.
Yeah.
Absolutely, keep it going.
Absolutely. Thank you.